So welcome everybody, and thanks for joining us for the first seminar of the Kirby Institute seminar series in 2022. I'm sure most of you know me. I'm Ben Babington. I'm in the HIV Epidemiology and Prevention Program, and I'm the chair of the seminar series committee. So of course, I'd like to begin by acknowledging the traditional custodians of the land on which we all gather here today in different places, and pay my respects to their elders past and present and emerging. So for me, this is the Gadigal people of the Eora Nation, and I extend that respect to Aboriginal and Torres Strait Islander peoples joining us today. So just some housekeeping to start off with. As it's the first seminar of the year, I thought I might just give a little bit of a blurb about what this is. Most of you will know this, but there might be some new people. So the Kirby Institute seminar series is our weekly opportunity to hear from Kirby and external speakers about research, policy and practice. And the series is coordinated by a committee, which is made up of myself as chair and a representative from each of the Kirby research programs, plus some members of the operations team. So as this is the first seminar of the year, Kirby people, please make sure that you find out who your program rep is for this year and pass on any ideas that you have for speakers to them. So creating this seminar series really is a collective effort, and we encourage you to be involved. So today, just to get started, the format for the seminar is that we'll start off with a presentation from our guest speaker, followed by a Q&A at the end. And you can ask questions throughout by clicking on the Q&A icon at the bottom of the screen and just type. And so we'll kind of order them later and ask the questions to our speaker. So now to introduce our speaker. So Dr. Heather-Marie Schmidt is the Regional Advisor for PrEP, jointly with the UNAIDS Regional Office for Asia and the Pacific, and the Testing, Prevention and Populations team at the WHO's Department of Global HIV, Hepatitis and STI Programmes. So as part of this role, she provides technical assistance to countries, organisations and communities across the Asia-Pacific region to support planning, implementation and monitoring and evaluation of PrEP programs. So she has policy, program and research experience across a range of public health priorities, including HIV, STIs, viral hepatitis, COVID-19, healthcare associated infections and non-communicable diseases, including at the Ministry of Health here in New South Wales and the Regional Civil Society Network, APCOM, based in Bangkok. So she's passionate about improving the public health response to help end HIV transmission across the Asia-Pacific region, particularly with the introduction of PrEP as an additional HIV prevention option. So please welcome Heather-Marie. Thanks, over to you.
So thanks, Ben. Today I will be talking about PrEP in Asia Pacific, and there's a few topics I want to address under this particular topic, and that includes providing an update on global PrEP guidance, which is very influential in terms of policy adaptation and program expansion in Asia Pacific, an overview of the HIV epidemic and PrEP policies and programs within Asia Pacific. Then we'll deep dive into some field visits and country examples, outline and discuss some of the key challenges in PrEP implementation, and discuss the future of PrEP or opportunities to accelerate HIV prevention in Asia and the Pacific. So WHO's first conditional recommendation on PrEP was made in 2012, and with ever stronger evidence for PrEP emerging from trials, from clinical studies, and from implementation, by 2015, WHO had released a strong recommendation for PrEP for people at substantial risk as part of combination HIV prevention approaches. And in addition, evidence from other trials supported the addition of event-driven and a second dosing regimen for PrEP, and this is known as ED PrEP, 211 or on-demand PrEP, particularly in Australia. In January 2021, WHO released a conditional recommendation for the first of a next generation of PrEP products. And this is the dapivirine vaginal ring, which is recommended as a new HIV prevention choice for cis women at substantial risk of HIV infection. So as I mentioned, WHO's recommendation came off the back of high quality evidence for the effectiveness of PrEP from clinical trials, open label extension studies, and real world implementation, which demonstrate oral PrEP's effectiveness. One thing to remember about PrEP is that it is highly correlated with adherence. PrEP works, but only if you take it. We have seen that the large-scale uptake of PrEP as part of combination HIV prevention has been associated with population-level decreases in new HIV diagnoses. And this has been really impactful in places like Australia, Scotland, England, and the US. But there are many other places, particularly low and middle income countries, that are yet to achieve the scale that we need to really affect a change in the epidemic. One of the things that we talk about less with PrEP, we often talk about the effectiveness, is that PrEP is also really empowering for the people that take it. It has immense psychological benefits, including reduced shame and fear associated with sex. And those are benefits that we don't often measure or promote. PrEP has been recognized, however, as an important HIV prevention tool by the United Nations, features in last year's political declaration and in the global AIDS strategy, and is integral to the UN 95% target for comprehensive HIV prevention by 2025. So why are we particularly interested in PrEP in the Asia Pacific? In the Asia Pacific, there are an estimated 240,000 new infections in 2020, which represents a decline of only 21% since 2010. Unfortunately, this figure also has significant variation by country and by populations within a country. While some countries have experienced declines, including Vietnam, Thailand, and Myanmar, others have rising epidemics, including Malaysia, PNG, Pakistan, and the Philippines. The Philippines is a particularly severe case with an increase of over 200%, almost 240% since 2010. Like in Australia, the epidemic is concentrated among key populations and their partners, who accounted for 94% of new HIV infections in 2020. And critically, key populations are underserved by the national HIV programs and particularly HIV prevention programs. These are often reliant on international donor funding, and this results in suboptimal coverage and contributes to continuing inequity. This is particularly severe in cases of criminalization, persistent stigma, and discrimination present in many countries in our region. And the situation is particularly acute for young people. While young people accounted for only 6% of the proportion of people living with HIV in Asia and the Pacific, they are accounting for increasing numbers of new infections. In 2020, almost over 1 in 4 new infections were among young people aged 15 to 24. The epidemics are rising, and young people are chronically underserved to an even greater degree than other members of key populations. Sexual health education, where it exists, is wholly inadequate and is largely heteronormative, may focus on abstinence or contraception-based sexual health. And young people are completely underserved by services that are not designed for them, and they are not accommodating of their unique needs and preferences, even where they are designed for key populations. Laws may also restrict access to HIV testing, to PrEP, and to other services to adults, or require parental consent for minors. And this is a major barrier for accessing services. And even where the laws allow it, clinicians may be reluctant to provide these services to minors. So we need to strengthen and innovate all services, including traditional HIV prevention and condom programs, but condoms alone will not solve our HIV prevention challenges in Asia and the Pacific. And I mention this specifically because this is one of the most common arguments I hear about PrEP, or against PrEP, should I say, that we should instead strengthen condom promotion. And this isn't and shouldn't be a zero-sum game. I really love this slide from Love Yourself in the Philippines, which provides some of the many reasons that people may not always use or want to use a condom. Different prevention options work for different people at different points in their lives and with different partners. And so condoms, PrEP, U equals U, harm reduction, etc., all have a really important place. But PrEP can help fill a gap in prevention as another strategy in that mix. And so looking in detail at the Asia Pacific, there is an increasing recognition of the potential for PrEP to contribute towards improving HIV prevention coverage and dramatically reducing new infections. There are increasing numbers of countries that are adopting PrEP policies and guidelines within the region. Last year alone, the Philippines, Laos PDR, India and Indonesia have all adopted new PrEP guidelines. However, local guidelines and the programs that they support have been slow to adopt some of the newer recommendations. And I don't know if I should really call it new. It was 2019, but let's go for newer recommendations, such as ED PrEP. And this is partially due to a perceived complexity in providing it and a perceived complexity of PrEP. But having a PrEP policy is not at all the same as having a program. In the 3 to 4 years, in the last 3 to 4 years, there has been a lot of increasing momentum. PrEP programs are expanded rapidly across the region. And this slide, I redo it every year and sometimes multiple times a year because it is changing. Countries are moving through from planning to demonstration projects, to post-demonstration phases, and towards national scale-up plans. But in our region, Thailand, Vietnam, Cambodia, and Nepal are all scaling up programs. Philippines is as well to a very different plan. And a particular feature is the diversity of access points and clinics, as well as the involvement of the community. And in most of these, the involvement of governments. And this is a feature you'll see when I do the deep dives into countries. And as you can see, most countries, however, are in very early stages of planning or are in early stages of implementation. So planning and implementation, access may be limited to small demonstration projects and is often limited to demonstration projects of a few hundred or maybe 1,000 people, is limited to certain geographical areas, particularly urban areas and capital cities, and is quite often largely reliant on the private sector, particularly in those post-trial rollout periods. Smaller scale demonstration projects have been started in countries like Laos PDR, Sri Lanka, Mongolia, Myanmar, and Indonesia at the very end of last year. But most of these have commenced in the last year or two. Further countries are advanced in their planning, including Pakistan and Timor-Leste, as well as India. Malaysia has PrEP available, but largely there is a need to buy PrEP through private pharmacies and clinics. In China or mainland China, private sector availability is also possible, although the cost has been a significant factor in reducing the access and uptake. At about $300 a bottle, this was very expensive for most people. The entry of generic manufacturers into the country late last year has the potential to improve access going forward, but national policies are really needed to support PrEP. One of the other things that's really important to note, because I have talked about some of these demonstration projects, is that as the planning and the conduct of these demonstration projects increases, the key message here is that we are not and should not be trialing oral PrEP. Efficacy, real world effectiveness is well established. It doesn't change if you're in China, Mongolia, or Australia, but we should be taking a rapid phased implementation approach. And there are a couple of countries, and particularly Cambodia, that have really taken on board this approach with a plan towards national scale up. And with the expansion of PrEP programs, there are more people than ever who are taking PrEP in the Asia Pacific. And I'm simultaneously very excited at how far we've come, but also recognize that the progress has been really slow. Asia and the Pacific accounted for less than 10% of PrEP users globally in 2020, despite having such a high population. And currently only about the number of PrEP users is only about 2% of the 4 million person target for 2025 under the UN. The number of users is not proportional to incidence, to prevalence, to PrEP need, and is not yet enough to affect the course of the epidemic in any of our low and middle income countries in our region. And this is a concern particularly for those countries I mentioned with rapidly rising epidemics, remembering that it's important that PrEP is rolled out at scale to really achieve a population level impact beyond the benefits to the individual. And so to reiterate what we all know or should all know by now, that there is a substantial unmet need in PrEP in the region and that expanding PrEP access and uptake is desperately needed. These are the results of a survey administered through Hornet of over 3,700 participants from 24 countries, the majority from Thailand and Indonesia. Using criteria broadly consistent with eligibility guidelines in the region, 57% of HIV negative and untested men may be eligible for PrEP. Of those, 30% have ever used PrEP, and only 1%, one third of those who are eligible actually believe themselves to be, 33% of those not believing themselves at risk, are eligible, demonstrating that particular unmet need. So let's take a look at some of the specific case studies within our region. And in the interest of time, I can't go through every country. I would love to talk about many of the countries that I won't get a chance to talk about. So just know that there are a lot more examples and really great practice. Please follow. I should do shameless plugs at the end, actually. So hold on for that. So Thailand first began providing PrEP as one of the first countries in the world in 2014 and has really evolved their PrEP programs over this time. Really, really importantly, Thailand became the first country in Asia to integrate PrEP under universal health coverage, the equivalent of our Medicare. And so this was formalized in 2021, but really that process began in 2019. And this has really supported the expansion of PrEP in both community or key population-led services, which is a really important feature of the Thai response, as well as the public health system. KP services or key population-led services are an important and really well-recognized feature of the approach in Thailand, which fills a real gap that traditional services leave for key populations. Key population-led services deliver a full range of services required by PrEP users, but also beyond and outside PrEP, without the client ever needing to formally see a doctor. Everything is handled by trained and certified peer workers, but a challenge in this model has been sustainable financing. Again, these models have typically been funded through donor funding, external donor funding, but very recently, community-led services are being integrated into the national approach with reimbursement through the universal health coverage system and through local partnerships with clinics and hospitals that allow for clinical oversight. Now, PrEP uptake in Thailand has increased from over 3,000 users in 2019 before universal health coverage to almost 16,000 users in 2021. And this is despite significant challenges with COVID-19. Almost 65% of PrEP users access PrEP through community-led health services to obtain PrEP. And so again, illustrating the real importance, but also the accessibility, availability, and quality of key population-led services. And so these services have really been prioritized. These services have also really adapted and delivered innovations through COVID-19 to improve their service delivery using express clinics, which are basically shorter clinics, much more targeted, much more streamlined, take much less time for the client, which is really great. Things like STI self-sampling, mobile drug delivery, digital and telehealth have all been features, and these have been really embraced by the community, not just by necessity, but also by the fact that they make PrEP even more acceptable, accessible, and available. Within Thailand, we're currently updating the national PrEP guidelines to ensure that PrEP is accessible to young and adolescent people at substantial risk. In fact, I think those might have just been released because this has been a real barrier in Thailand. Services are not designed for young people. And again, as I mentioned, clinicians are frequently uncomfortable providing PrEP to young people. PrEP, a pilot for PrEP, for people who inject drugs through an integrated one-stop approach, community-led services, is being in the current stages of being planned. It's been a particular gap within Thailand. And I also want to highlight some of the services, including the Tangerine Clinic, which is a real example or an exemplifier of the key population-led services within Thailand and the innovative approaches to delivery. The Tangerine Clinic delivers sensitive, appropriate, comprehensive care for trans and gender diverse people, and part of their continuous quality improvement, and as part of their continuous quality improvement, they decided to really rethink the way that they're delivering, particularly their counseling, but also their services for PrEP, and shifted towards again framing messaging, raising risk awareness through syphilis. And this has contributed to increased uptake, but also increased continuation among trans women, which has been really fantastic. But continuing 16,000 people is a real drop in the ocean in terms of PrEP need in Thailand. Continuing efforts are really needed to rapidly scale up PrEP and to make use of PrEP's potential to change the course of the epidemic. And as I mentioned, it's only a drop in the ocean, these 16,000 people, with just over 150,000 people estimated to be eligible for PrEP. So Vietnam is another regional leader within in PrEP scale up within our region. In 2021, Vietnam's program has dramatically expanded to now provide PrEP to over 26,000 users. These are current users. And this is despite, again, the challenges of the COVID-19 pandemic. Civil society and innovation are really hallmarks of the PrEP programs, as is multi-sectoral involvement with key partners across civil society, insanely great engagement from government, research, donors, implementers are all collaborating. There is a diverse range of models that have been implemented within Vietnam, including community friendly and key population-led clinics, comprehensive services, mobile PrEP, tele-PrEP. Again, taking an approach towards client-centered approaches to increase demand, awareness, and also the delivery of PrEP services. One an important factor is that PrEP services are subsidized, but not completely free, and there is a small fee contributing towards the cost of PrEP services. However, PrEP is really looking at innovating in the way that they want to deliver PrEP, and they're really constantly improving their approach. And this included them being an early adopter of event-driven PrEP in 2019, just a couple of months after it was released by WHO. And they are finding that ED PrEP and PrEP in PWID is safe and effective. They are one of the leaders in terms of PrEP for adolescents, having no restriction in terms of age, and provide PrEP across the range of key populations. They're also innovating in terms of their monitoring and evaluation tools, which provides the evidence they need to further scale up, to fund PrEP, and this has included national electronic modeling tools. Vietnam also has a 5-year scale-up plan that they released in December 2020, and they aim to provide PrEP to over 72,000 or at least 72,000 individuals, a little bit less than half of their estimated need. And this is setting a new benchmark for speed and scale up within the region. One of my favorite countries to talk about is Cambodia, and it is another outstanding example of PrEP within our region, but Cambodia is much smaller, has a much smaller epidemic than places like Thailand and Vietnam. And so it's really amazing to see, I would consider such a small country doing such amazing work. Cambodia launched its program for PrEP in 2019, so it's one of the more recent PrEP programs, but they completely skipped a demonstration project. There has never been a demonstration project in Cambodia. And instead, they have taken a very pragmatic and phased approach to implementation. They have a goal to reach all 15 of their high burden provinces for HIV infection and to engage 5,000 clients on PrEP by 2023. By August 2021, there were almost 1,500 clients on PrEP in 10 sites across 5 provinces. There has just been a new site offered, which brings it to 11 in a new province, which opened just last week. And again, like, I'm going to keep highlighting this, but I think in Australia, we're not necessarily as cognizant of how much disruption COVID-19 has had within the region in terms of travel restrictions, in terms of lockdowns and curfews, and in terms of people needing to move back to home provinces where things like PrEP may not be available. So there are real impacts of COVID-19 in terms of service provision. And so these are really remarkable achievements. Like in most of the countries that we've spoken about, the majority of clients are gay and other men who have sex with men and trans women. And there is perhaps two of the things that, besides the phased implementation, I really want to make sure to address is that Cambodia is also really innovating in terms of real-time data tracking. And so they're piloting this in 3 sites in Phnom Penh with a plan to expand to all of their further sites. And this will really, again, allow them to collect meaningful data to support not only their scale up, to justify investment, and to really ensure quality and safety within their programs. And the other thing, and again, recurring theme, is the multi-sectoral partnership that has been really crucial to the entire planning and through to implementation, including government. And government has been really a driving force within the PrEP program. This is not something that we should take for granted. Again, I think in New South Wales in particular, we're probably a bit spoilt with the leadership that there was. This is not a given. Community, implementing partners, other partners, CSOs intimately involved in prevention services as well as demand creation. This multi-sectoral partnership has been really instrumental. In the Philippines, I mentioned the situation is a little bit different, and PrEP is beginning to expand more rapidly, and I've included it here as more of an example by what can be done by clinicians and civil society when they really value and need something. So the CBO Love Yourself originated the project PrEP Pilot Project, lots of P's there. The model used a community-friendly based setting, task sharing with peers, and with activities like PrEP information, counseling, eligibility assessments. And now that the pilot is finished, and it finished actually a reasonable while ago, the activities, sorry, I got a random notification. And the pilot has finished, and it had really good results in terms of self-report and objective adherence measures, continuation. And so now that the expansion phase, the focus has really shifted far more towards differentiated, client-centered, and peer-driven approaches. They've, again, streamlined consultations, integrated PrEP with other online activities, increased demand generation, and creating safe online spaces for people who are using PrEP. And really, again, expanding those PrEP access points. Love Yourself have their own clinics, but other CBOs, including Hash, offer PrEP private practices, including SHIP, which you'll hear about if you follow the Philippines, as well as diversifying to online access points and using diagnostic facilities for tests, which means that they can really capitalize on telehealth and medication delivery services. To the end of 2021, there are now 4,000 to 5,000 people using PrEP, which is a massive scale up across a range of clinics and providers, but there is still real geographical inequity in access. Access is very, very limited towards major metropolitan cities, including Manila. And there is a substantial need, particularly when, as you will recall, infections in the Philippines are increasing at a rapid rate, and particularly among young people. But PrEP guidelines in early 2021 and listing in December on the national formulary is paving the way towards national purchasing, which hopefully will start to embed PrEP within the range of services that are available as part of public programs. Sri Lanka is a bit different. So I really wanted to highlight Sri Lanka as an example of a PrEP program that is much newer and that is really trying to actively overcome challenges. Sri Lanka's PrEP program was initiated in 2020 in a government STI clinic in Colombo. It had a strong focus on adults who identified as gay and other men who have sex with men, or trans women. I think it may be accessible to other gender diverse individuals, but I'm not 100% sure. They did, however, incorporate both daily and 2-1-1 dosing, and have really tried to use community engagement, referrals from CBOs, online outreach, but there is a somewhat more limited involvement. There are no key population-led clinics, for example. But what they were really noticing is that after a year of implementation was incredibly slow. Even despite the COVID-19 challenges, implementation was still really, really slow. And so to really understand this better, they conducted focus group discussions. And what they found was opening hours were a massive, massive barrier. They've started a PrEP clinic, and PrEP uptake increased by 50% within a month, just by having a Sunday clinic, which really shows the importance of really designing your programs around the needs and preferences of the people who need to use it, rather than necessarily the preferences of the clinicians who want to deliver it. There is plans for integration to all of the STD clinics across all of the provinces in Sri Lanka in 2021, and models of differentiated service delivery are something that they really want to incorporate. They also really want to focus less on risk, which again has been a real challenge within Sri Lanka, and shift towards more gain framing messaging. There are other things like telehealth, expanding to other populations, co-packaging with HIV self-testing, and HIV self-testing is also being trialed in Sri Lanka, and considering PrEP availability in pharmacies, because with only about 140 people enrolled, despite a relatively smaller population and epidemic, there are an enormous number of people who would benefit from PrEP who are currently unable, or who are currently not accessing it. So I didn't mention that reframing of the conversation to gain framed messaging and positive messaging to boost awareness and demand. And this is something that I think we've used examples from Australia within the region, because organizations like APCOM have done it so well. In Asia Pacific, demand generation campaigns are largely driven by community organizations. And there has been a more recent shift, although it's 100% not universal, but towards more positive, empowering, fun, and sexy messaging. And this is really helping to start to normalize PrEP as part of a suite of options available to reframe conversations away from risk. And I mean, we need to do much more work in the clinics towards this, and much more towards benefit. But few countries have had the kinds of public campaigns that we've seen in places like Australia. One notable exception is the, and what I hope is the first of many similar campaigns, is the PrEP in the City campaign. This is Asia's first trans-specific PrEP campaign and was launched in September 2020. Gain framing messaging is a central theme. It features 4 trans women influencers and is designed by, produced by, and for trans women. It aims to empower trans women to take control of their HIV status and their health. It conveys experiences of using PrEP in daily life. It's gain framing. It is empowering, and it aims to change that perception again away from risk towards these much more powerful messages. It has social media and offline components, including some very public components, including, as you can see, an example from a bus, as well as billboards. And but it was not without its controversy when it was first launched. This is really a very groundbreaking start to a conversation and a start to the way to provide PrEP demand generation. COVID-19 has resulted in massive programmatic disruption across the region to HIV programs, but particularly PrEP programs, which are really not seen as a priority in terms of resourcing. Not only with lockdowns and travel restrictions, even things like traveling to a clinic to access your PrEP was fraught and problematic at various times within Asia and the Pacific. But there have been some advantages, and COVID-19 has really proven successful in terms of really inspiring some amazing innovations. There has been a much more increased use of self-testing, self-collection for HIV, HCV, STIs, community distribution sites, pharmacy models, mobile distribution. Amazingly, multi-month dispensing of prescriptions is not something that is necessarily common within our region. COVID-19 has helped to normalize that. There has been a simplification. I've mentioned express clinics and streamlined clinics, and some support for more of a shift towards differentiated service delivery. And these include models like community and key population-led services, as resources become more tight. And virtual space has been incredibly, incredibly important. I don't know how we might have survived had the pandemic come at a different time in terms of a virtual space for information, demand creation, ordering supplies and tests, for telemedicine, for counseling. The challenge here is for this to become embedded within PrEP services going forward. And there is some hesitation when the pandemic ends about continuing things like telehealth. So there are a number of lessons from the countries that are implementing PrEP in the AP, and these are from some of the examples I've mentioned, but also from others that I haven't. Partnership, engagement, collaboration at all levels. Government, community, clinicians, implementers. If all of these groups are not on board, PrEP uptake and access will continue to be at the couple of hundred people level. It will continue to flounder in private sector. PrEP needs to be available, accessible, acceptable, affordable, adaptable, differentiated. And there's a real need to diversify the range of locations and service types. People who would benefit from PrEP need to be central to service design and implementation. And while key population-led services are often preferred by potential users, other service types are really important, and this includes that integration. Primary care is not as big in Asia as it is in Australia, so that integration needs to happen at many, many more points. PrEP has to be included in that national response, in strategies from the National Strategic Plan to their policies to national health insurance, domestic resource allocation, if we are to achieve scale and impact, because standalone services are not efficient, they're unsustainable, they miss opportunities for comprehensive care. So we need to integrate, we need to have e-health integration, integrated M&E, so that there are no excuses not to implement PrEP. Criminalization, stigma, and discrimination are major barriers, and I haven't addressed that hugely, but these are pervasive barriers to PrEP. And so that positive gain-framed messaging and normalizing PrEP are really, really important going forward. But we can do a lot with community, we can do a lot with the general public, but we also need to really sensitize and support providers to really deliver this stigma and discrimination-free and empowering service delivery, particularly where we start expanding it beyond the services that we're currently associating with PrEP. And I'm not going to go into the COVID-19 disruptions because I've just mentioned them, but the thing here is really, really about maintaining them. So if we take a step back, and we sometimes think about a person's PrEP journey like this. It's really simple, and this is how our programs are designed, these are how our policies are designed. This is how we monitor people, we judge adherence. But in reality, live PrEP journeys are far more complicated. And so we need to make sure that our programs and our policies are accounting for all of this. Some of that work is starting to happen in Asia and the Pacific, but again, a lot of the monitoring and evaluation looks at 3-month continuation. They look at models that really go, that look at PrEP like this rather than like this. And so one of the things that we're working on with WHO is making programs, policies, practices more flexible, adaptable, and to take into account these kinds of complications to best meet the needs of people who would benefit from PrEP. WHO is working on guidance to simplify the delivery of PrEP, to ultimately make it easier for programs to fund it and to deliver it, to reduce excuses not to provide it, and to remove unnecessary barriers to uptake while still ensuring safety and quality for PrEP users. New and upcoming guidance includes kidney function monitoring. We have already globally reduced some of the requirements from this. And so that includes individuals under 30 years who do not have any kidney-related comorbidities. Kidney function monitoring is optional. For other groups, it can be done within 1 to 3 months of initiation, which facilitates same-day initiation. HIV self-testing as a really important enabler, and it has really real potential. We're still evaluating that and don't currently recommend it to initiate or to continue PrEP, except in the context of COVID-19 pandemics, where it has been instrumental in allowing PrEP services and individuals to continue on PrEP. Viral hepatitis testing, and the 2 points I want to highlight about that one is that both for hepatitis B and C, these are really important opportunities. PrEP services are really important opportunities to deliver viral hepatitis testing, but viral hepatitis should not delay or stop provision of PrEP. One of the really important things is that hepatitis B positivity used to be a contraindication for event-driven PrEP, so 2-on-1 on demand. We have now evaluated that and removed that requirement. So that is now no longer a prerequisite to providing event-driven PrEP, and we recommend that viral hepatitis testing should be done within the first 3 to 6 months. And another big change is starting and stopping PrEP. And event-driven PrEP, which isn't on that list, but should be. It's related to starting and stopping PrEP. So one of the big changes is that ED PrEP formerly was only recommended for men who have sex with men. And so the eligibility for event-driven PrEP has now been expanded to all individuals who are assigned male gender at birth who are not taking gender-affirming feminizing hormones. So this includes trans women, non-binary individuals, cis men who have sex with men, but also cis men who are having heterosexual sex. And crucially, this also means that starting and stopping PrEP for all of these groups is the same, whether they intend to use event-driven or daily PrEP. 2 pills, 2 to 24 hours, ideally closer to 24 hours, prior to the first sex, bearing in mind it is only for sexual risk exposure, and two pills for 2 days after the last sex. For all other groups, daily PrEP is recommended and remains recommended, and so this includes people who inject drugs, as well as individuals who are assigned to female at birth and individuals who are using gender-affirming feminizing hormones such as estradiol. And so the starting and stopping regimen here, 7 days to start, but has been reduced from 28 days to 7 days to stop. Our service, we're also looking at not necessarily recommendations, but advice on differentiated service delivery to really increase PrEP uptake. And so in addition to simplified delivery, there are new PrEP products that are on the horizon that are expected to deliver more choice, but also new challenges for PrEP implementation. A few to support improved PrEP programming, advocacy for PrEP availability, accessibility, product choice, and guidelines and approvals processes. We're in the process of commencing 2 projects, including an acceptability and feasibility assessment for the Dipivering vaginal ring. As I mentioned, this was recommended last year by WHO, but has really only been assessed in Africa. That's where rollout is happening. There is no information on acceptability and feasibility within Asia. There are particularly groups who would really benefit potentially benefit from access to the Dipivering vaginal ring in Asia. And also a values and preferences assessment for PrEP products and services, which includes oral daily PrEP and event-driven PrEP, as well as long-acting injectable cabotegravir. Now, long-acting injectable cabotegravir is the next of the next generation of PrEP products that will become available. So what we found is that PrEP is, injectable cabotegravir, CAB-LA, is highly effective in adult men who have sex with men, in trans women, in adult cis women, and there are ongoing studies in adolescents, but there have been some enrollment challenges. There are these CAB-LA, some of the sites were in Asia, which is fantastic, including Vietnam and Thailand. So there is direct local evidence, and hopefully that will facilitate adoption of CAB-LA. And there are planned implementation studies. CAB-LA was approved by the FDA in December 2021. And will be assessed at an upcoming WHO guidelines meeting in March 2022 to determine whether WHO makes a recommendation. There are some outstanding issues with CAB-LA, including drug resistance at initiation, during use, and the long tail, because as an injectable, it does have a long half-life within the body. Safety during pregnancy and breastfeeding, implications for HIV testing, other implementation challenges, including service delivery. There has been limited representation of some key populations, including trans men. In fact, I think no representation there. And there are questions around pricing. So, outstanding implementation issues, just to finally to sum up, there are a lot. This is by no means a comprehensive list. I wish it was. But improving that accessibility, availability, acceptability, affordability, adoption of digital innovations. One thing that I hadn't mentioned much, but it's around mosaic programming and balancing service integration with specific services, because one of the features of Asia Pacific is very much vertical programming barriers, but where HIV services are delivered really separately from related services, and HIV is over here. So we really want to break down those barriers and make sure that we move much more towards client-centered care. We really need to make sure that complementary services that are needed and valued by communities are offered, and that PrEP, so bidirectional integration, that PrEP is offered in the context of these services. We need to also shift towards prevention effective adherence. And again, this is recognizing the complexity of a PrEP journey and patients' lives, because, you know, measures of adherence tend to show that adherence is suboptimal, and that groups require additional support, that there's also early discontinuation. But these measures rarely take into account why people may have discontinued, why adherence may be poor, and really use our, you know, have you been taking PrEP at, you know, these points or for this long, rather than looking also at risk. So much more nuanced approaches are needed. And strengthened and integrated monitoring and evaluation systems. I think over time, PrEP awareness and access needs to be rapidly expanded. PrEP is woefully available within Asia and the Pacific. And there needs to be a political commitment to HIV prevention and PrEP to achieve that introduction and scale. And this includes regulatory approval, it includes training, it includes differentiated service delivery, and allowing pharmacists, allowing key populations, allowing nurses to deliver PrEP. We have the introduction of new products, and they will integrate. And I use disrupt here as a positive thing in the way that IT uses disruption. And hopefully they will disrupt the status quo to really improve services and prevention, and to increase the number of people who are able to access and who do access PrEP. But pricing remains a question, as does acceptability, feasibility, and implementation in low and middle income countries. And stigma and discrimination must continue to be at the forefront of what we're doing, addressing that. So I really want to thank everybody who contributed to this presentation, but particularly all of the PrEP advocates, allies, users, implementers, providers, policymakers, researchers, and community across Asia and the Pacific, because without them, we would not be nearly where we are. And it's their passion and their commitment that has been instrumental in getting us here. So thank you.
Great, thanks so much, Heather-Marie. So we've got a couple of comments just saying fantastic presentation, really interesting and informative. We've only got a few minutes left, so we probably won't get through a huge amount of discussion, but I didn't want to stop you because I think the content was just so interesting itself. So we had a question from Philip Keen. I think this will be fairly brief, just to say it's great to hear about the mobile PrEP and tele-PrEP in places like Vietnam and Thailand. Do you know whether the ways that people are assessed for PrEP and require approval by a doctor, or is approval can be done by other types of people?
So, okay, so the assessment is done in places like Thailand by a peer, but there is clinical oversight that is provided by a clinician. So all of that is in the back end. the client would never be aware that they're seeing a doctor. And so the medication is dispatched quite often by a drug delivery service. We use a lot of motorcycles to deliver things, just like food. You can order everything using a mobile service delivery. So yes, there is clinical oversight, but in terms of client facing, it's done by a peer. That's much more common than pharmacists or nurses. That doesn't tend to happen very often in Asia Pacific.
And we got a question from Yanis, which also kind of aligns with one that I wanted to ask as well. And I have no idea what time it is, Yanis, wherever you are, but welcome. It's fantastic to see you.
12 hours. So, 16 hours from you.
Yeah, it's crazy. So do you think there is value in primary care involvement for PrEP in Asia? Or should we continue more along these lines of the key population-led sort of services? And my question was sort of similar, like, do you think we could ever get to a point in Asia where it's just like it is in Australia, where any doctor is able to prescribe?
Okay, so, I mean, I think primary care absolutely needs to be integrated into the mix of services. We also just need primary care in Asia. Like, that needs to be a much bigger health service, a much bigger health service within Asia and the Pacific. So yes, primary care though shouldn't replace specialist services. What we want to do is really increase the mix of services that are available and that provide PrEP. PrEP is not complicated for people to deliver. It can be effectively delivered, with a little bit of training, not a lot, by, most doctors, no, all doctors. I'm not even going to say most doctors. It can be delivered by all doctors. It is really very simple to deliver. You don't even need doctors to provide it. Nurses are eminently capable and trained to be able to provide it. It's mostly boring for doctors, but it may not be boring for, your doctors specializing in sexual reproductive health, for your doctors who are in emergency. There are a lot of places that people interact with the healthcare system where they should be able to access PrEP. So, and PEP as well. So I would say actually the same for PEP. It should be available in all of these places too. Complex referral pathways don't help anybody. And in fact, what we see is that where people present for PrEP to providers who don't know about it, those complex referral pathways can really be a disincentive. So we need everybody to be trained up on HIV prevention if we're going to have any hope of really ending transmission and supporting people. So yes, everywhere. I want PrEP to be available everywhere. And I'm also like, pharmacies are great. Let's make it available.
Yeah. So we've really only got 1 minute left. There is only one other question though, so we might as well just ask it. And people, if you have to leave, please go, but we'll just stick around so we can get this answered. So Curtis Chan has said, great talk. You mentioned making ED PrEP simpler to understand and that it shouldn't be complicated. And so could you speak a little bit about how to communicate the 2-1 method easier for end users to understand throughout the Asia Pacific region? Because we know in many areas that's been an issue.
That is an amazingly great question. I'm so glad you asked. Because I think that part of the confusion, or part of the reason that a lot of communities, individuals, providers thought it was complicated is when we had different rules for if you were starting ED PrEP or if you were starting daily PrEP. And so the same person could, if they were doing daily PrEP, they had to wait 7 days to start. And then if they wanted to stop, they had to wait, 21 or 28 days. But if they were only taking ED PrEP, then it was only 2 pills to start and 2 days to stop. Basically, because we've simplified this, and depending on who you're talking to, if you're talking to somebody who is eligible for ED PrEP, so any individual who's assigned male at birth and not taking gender affirming hormones, who has sexual risk or sexual exposure, it is the same way to start and to stop. Doesn't matter if you're doing ED PrEP or daily PrEP. 2 pills, 2 to 24 hours to start. Continue taking it while you're still having sex. If that's 1 day, you just have it 1 day and then you stop with the 2 pills. And if that's a whole weekend, or if it's 3 years, you continue to take it and then 2 days after your last sex. So there are really nice little diagrams that just show how you just add more pills, basically. If you are taking just for one event, it is important to be more, that's where we do emphasize adherence. What we know for cis men, PrEP is pretty forgiving if they're taking it daily. They miss a pill, 2 pills, even 3 pills, their protection is still way over 90%. So I think that's where we want to demystify things, start and stop the same way, and just, and then they can also swap between daily and event driven as suits their needs, because you don't want to be taking PrEP. And this is one of the things that results in poor adherence and discontinuation. If you don't need PrEP, then you can stop and you can start again. And it's really easy to stop and start again. And so that's where really great conversations are really important about how to empower people to take control of their own PrEP journeys.
Yeah, absolutely. I think it's definitely, you've picked up there, one of the words you use was the perception of it being complicated. And I think that's something that we need to kind of get over and figure out just ways of communicating it in a more simple way that people can kind of understand and get past some of these barriers that we are picking up in research. But I think they're not insurmountable at all, which has been shown, in France, Belgium, and the Netherlands, where more than 50% of people are doing ED PrEP.
And I think one of the things is where countries have started with ED PrEP and daily PrEP together, I feel like anecdotally, I'm hearing less issues. It's where they've introduced daily PrEP, have one particular scheme, and then they introduce event-driven PrEP, and people are confused. They're like, oh, but how does this work? Why is the advice different? And I think that's where one of the issues is. It's people like consistent advice. I think you're muted, Ben.
And there. Thanks so much for the people who've hung on right to the end. We're just like a few minutes over time, but once again, just thank you so much, Heather-Marie. That was just such an interesting presentation, just with so much information. There's a message here from Tony Keller saying, just great presentation, plus, plus, plus. So really, thank you so much. And for kicking off our seminar series for the year. It was really great to have you. And we look forward to seeing you around in the future.
Thank you very much. Oh,
Great.
And shameless plug for anybody who's still interested. WHO Global PrEP Network hosts webinars. I try and feature examples from the Asia Pacific quite a lot. So just Google WHO Global PrEP Network. You'll see our previous webinars. Please join our mailing list, join us, and hear more about what's happening around the world.
Absolutely. Great. Well, thanks, everybody. We'll end the webinar there and see you next week, Kirby people. Thanks very much.